Hello, and welcome to our strategy presentation regarding the reduction of unnecessary transfers to and from skilled nursing facilities, or SNFs, and the improvement of communications surrounding those transfers. As a brief introduction, our challenge lies against the backdrop of increasing COVID infections at Maplewood Manor, one such local SNF. Inspired by the plight of one such resident, Dottie, our team decided to tackle the problem of optimizing resident care with the constraints of infection prevention. Currently, the facility is experiencing a shortage of PPE, with staff expected to reuse the same PPE for approximately 2 to 3 days against a prevalence rate of between 29 to 43% of residents confirmed or suspicious for COVID infection. The backbone of our intervention considers primarily the reduction of infection rates by streamlining resident transfers to outside facilities and communications pertaining to them. The minimization of unnecessary and avoidable transfers is critical to the reduction of overall COVID transmission rates within SNFs. Without adequate support, SNF staff may have difficulty evaluating the appropriateness of transfers, and hotlines similar to the county's COVID hotline can provide support to fill that gap. Lack of communication between SNFs and recipient facilities can lead to worse health outcomes for residents, and the streamlining of communication, whether by telemedicine or traditional means, is central to our approach. Along the way, you will find that several ancillary components of our plan will likewise lead to improvements in resident quality of life alongside improved infection control. Our approach to this problem consists of 3 prongs. 1. The streamlining of transfers and minimization of unnecessary or avoidable transfers. 2. The reduction of communication errors associated with patient transfers. And 3. Improved access and frequency of telemedicine appointments. These are projected to lead to improved health conditions for both residents and staff. Our SMART goals for measuring the impact of this approach are siloed into 3 commensurate outcomes. 1. A reduction of transfers for potentially avoidable conditions. 2. A decrease in COVID-positive cases over the next month. And 3. An increase in telemedicine utilization among residents. The SMART goals themselves consist of 1. A 20% reduction in transfers for potentially avoidable conditions. 2. A 30% reduction in COVID-positive cases over the next month. 3. A 50% increase in telemedicine utilization among residents. These goals will be measured through weekly Plan, Do, Study, and Act cycles, or PDSA cycles. Reorganization of staffing and staff initiative will play a key role in ensuring success. To achieve this, we will adopt the following protocol for our residents. At this time, at the beginning of each weekly PDSA cycle, or whenever changes in resident health or behavior are noted by staff, residents will receive a risk stratification graded from Roman numeral 1 to Roman numeral 4. This is noted in Table 1. Grade 1A denotes patients with no symptoms suspicious for COVID and no chronic conditions that require transport on a regular basis. Score 1B describes residents that do require such transport, for example, for dialysis, while grades 2, 3, and 4 describe residents that have only 1 symptom of COVID, 2 or more symptoms of COVID, or a positive swab for COVID, respectively. At the same time, housing arrangements for residents shall change based off these risk stratifications. Wings A and B of the first floor will be dedicated to grade 4 residents awaiting transfer to outside facilities, while wings A and B of the second and third floors will be dedicated to the housing of grade 3 residents. Grade 1 and 2 residents can remain where they are pending precautions for symptoms suspicious for COVID, and will have access to socially distanced communal spaces and courtyards. If a resident displays new onset symptoms of COVID, appropriateness of transfer is evaluated by staff following the algorithm in Figure 1 by a socially distanced staff member clad in PPE with an iPad. These determinations are recorded on a brightly colored sheet that travels with the patient. What is recorded in the sheet is summarized into the 5 C's of communication. 1. The course of SNF stay. 2. Comorbidities. 3. Current medications. 4. COVID status. 5. Contact info for pertinent service and family members. This is where the hotline system comes in. This proposed hotline can aid not only in Maplewood Manors, but all SNF staff in determining whether SNF residents can be seen through telemedicine or if transfer to an outside facility is absolutely necessary. Comorbidities assessed on this questionnaire consist of cancer, CKD, COPD, obesity, heart failure, among other chronic diseases. Grounds for admission will likely comprise severe dyspnea, low oxygen saturation, or other concerning vitals or physical findings. Follow-up telemedicine calls can be made from within patient rooms. This hotline can be staffed by physicians or resident physicians already affiliated with the department, with funding support acquired through federal, private, or state grants. Similarly, this represents an opportunity for the improvement of facility wireless infrastructure. Hotspots will be made available to each wing of each floor to ensure not only the capacity for telemedicine visits, but also for the resident usage of wireless communications with family and friends. Residents will be prepared for transfer according to Figure 2, and or received from transfer in the staging area specified in Figure 3 on the building's first floor to mitigate new infections. To recap, our new system has several strengths, among which are our new hotline, which provides convenient and objective information on whether or not to transfer patients. Decreasing costs by preventing unnecessary transfers, and also by preventing transfers, our resident-centered system will decrease the incidence of delirium in residents by sustaining a continuum of care. Improving communication by consistently relaying relevant information during phone and video sign-out, which will be replayable by both EMS and hospitals. Our system will also travel with concise physical documents containing relevant information conveniently printed on bright-colored paper to avoid it from getting lost. Residents will also have increased access to specialists by conveniently being able to attend their appointments from their room at Maplewood Manor. Residents who are hard of hearing or require an interpreter will also benefit from telemedicine visits through the addition of closed captioning, which will ensure they are more engaged during their visit. We are aware of limitations during this intervention, including 1. Limited wireless capacity. SNFs should ideally invest in increasing Wi-Fi access and training healthcare workers to use video platforms with residents. However, the initial cost of Wi-Fi and hardware may quickly be offset by potential cost savings from reducing unnecessary transfers and lower COVID-positive rates in hospital. Another limitation includes access to tech. Facilities can have 1 or 2 communicarts set up for telemedicine appointments to offset this difficulty. Staffing shortages and competing demands are a possible limitation given staff might abstain from certain clinical interactions they believe might expose them to COVID. We did not go into detail about floor plan arrangements, the logistics of transfer, or changes in staffing, but we welcome questions pertaining to these areas, since those are likewise critical to this plan's success. Thank you for listening to our presentation.